Hello, I'm Doug Dormer, founder and CEO of White Pine Systems, and this is an introduction to SPINN, the Secure Personal Information and Notification Network. This is a series of slides with the audio narrative accompanying each slide. Each slide really stands as a vignette, a commentary on its own, so you can move forward, move backward, jump around as you see fit. And this is me. This particular picture is at the start of the Dexter Ann Arbor Half Marathon in May. It was a rather cold day in the 40s with a downpour for about 2/3 of the half marathon. Because this is me at 13.1 miles later, hat in hand, looking a bit worn, which is a reasonable metaphor for what's going on in healthcare IT, although it's a lot longer than a half marathon or even a marathon, and I admit I sometimes feel like this on more occasions than I'd like to admit. And this is my folks, my mom and dad, Dick Dormer and Lorraine Dormer, and my dad's guide dog, Mike, on their wedding day in 1953. I thought I would use them as a starting point for my introduction to who I am and why I think I may have some value for you in today's discussion. My folks were both blind, each from different causes. My dad went blind as the result of diabetes. In fact, he was one of the first 3 people ever, little children, to receive insulin as a treatment for diabetes. One day in 1961, he had a reaction. No big deal in our house. Too much insulin, not enough insulin. And the ambulance took him off to the hospital. Only that day, in our small town, Marquette, in the Upper Peninsula of Michigan along the shore of Lake Superior, the ambulance took him to the other hospital in town where he wasn't known, where he wasn't a frequent flyer. They assumed he was drunk and left him on a gurney to sleep it off, which is where he died. So while the direct cause of my dad's death was diabetes, the real cause was a lack of health information exchange, a lack of care coordination, a lack of patient empowerment. Those are the very issues that we're here to talk about today, 55 years later. Now, I've been involved in this field for quite some time. I'm not a physician, I'm not a psychologist, I'm not a clinician, and I hold people who are in those professions in such regard that I admit to a bit of, a bit of reluctance, a bit of reservation when I present my ideas on healthcare. And yet I have been involved in this business for a long time. I studied economics and in particular risk models at the University of Michigan. Based on that work, I was hired by Coopers & Lybrand, now PricewaterhouseCoopers, where in the mid-'80s I co-wrote one of the first books on diagnosis-related groupings, DRGs, to be able to get at the idea that hospitals and departments should think of themselves as profit centers rather than just cost centers. Later, I had the opportunity to work on the revolution in online technologies and consumer engagement in financial services. More recently, I've been involved in taking those notions and applying them to the world of healthcare and healthcare IT. I'm honored that I was recognized by HIMSS, the Health Information Management Services Society, with their Spirit of HIMSS Award in December 2012. Now, I don't view myself as an expert in the field, but I do view myself as a facilitator, as a moderator of the discussion. And so it is my hope that I can give you value today, and that you will also give me and the community value by reacting, by correcting, by expanding the ideas we set forth here. Let's start with a quick look at the nation as a whole and the state of healthcare. The United States ranks number 1 in cost per capita. Hardly something to brag about. It ranks number 37th in terms of effectiveness and delivery. And it ranks number 46th in terms of efficiency with which those outcomes are delivered. One place in 2012, one place below Iran. And while there are many causes for this, Certainly a large part of it is the fragmented and siloed way we have built our healthcare system, with physical health largely separate from behavioral health, separate from social supports, and separate from criminal justice, each of which needs to be integrated into a cohesive whole if we are to be effective. One of the ways we can improve our efficiency, improve access, lower the cost, and improve outcomes is through the use of telehealth. Now, I'll use telehealth and perhaps telemedicine largely as equivalent terms, all fitting within a broader notion that we'll call connected health. So when I speak of the technology side of telehealth, I'll be talking about live video encounters. That's what we most think of. A doctor in one place or a specialist in one place and a patient in another place, whether it's a primary care physician talking to a specialist in office to office, or whether it's a counselor or clinician speaking to a patient at home. Live video is certainly a key piece of it. A second piece of it would be community care coordination and patient engagement, where we take online tools, some call this store and forward, where we take the workflow and move as much of it as we can to online and mobile applications, increasing access and convenience, and capturing new data not previously captured before. Certainly it includes devices and remote monitoring tools, whether it's a Fitbit or a home glucometer or a blood pressure device or a motion sensor. And while not technically a part of telehealth, integration to traditional electronic health records and practice management solutions certainly is a key. Here's a great slide from our friends at Chilmark Research describing where we are today with respect to telehealth and where we will be in 3 to 5 years. As Chilmark describes it, we're now in a first wave of telehealth solutions consisting primarily of wraparound kinds of services, access to physicians through video encounters during non-standard hours, for specialists that are otherwise remote. These are urgent care, primary care, some specialist calls such as psychiatry, really delivered on demand, although increasingly we see scheduled events, where the encounter really exists as a standalone event, not a part of the ongoing treatment, not integrated well into the electronic health record, not integrated into the continuum of evidence-based care. Where Chilmark projects that we will go is into the second wave, where we have extending not just the video encounter, but to the online workflow, the store and forward, where we have integration into the EHR, and where all of it follows a consistent evidence-based practice throughout the continuum of care. Now I'd like to introduce the notion of a care unit. A care unit is a specific health interest or set of health interests that can be defined and applied to the interaction between providers and patients. So diabetes, COPD, hypertension are easy ideas of what a care unit might be. But it might also be a therapy like anticoagulation therapy, where the conditions might be quite broad, but the therapy is a specific set of health interests. It also applies certainly to behavioral health aspects, a care unit for substance use disorder, a care unit for criminal justice, people re-entering society that follows models of needs, risks, and responsivity. It might also apply to social conditions, employment. So we see the notion of a care unit is the first thing. We have to define what it is we're talking about as we think about how we might apply telehealth to it. Next, we must say that if we're going to look at those care units that we need to address, we need those where there's a large population and where the care unit or the set of interests are expressed through a common manifestation. They have a lot in common with each other. There also has to be an evidence-based practice that we can follow, some at least common guidelines. So in the case of, for example, substance use disorder, the recovery-oriented system of care, while not a rigid protocol per se, does provide sufficient guidance with sufficient common tools to allow us to say it is supported by evidence-based practice. And we have to have an area where demand exceeds supply. And that means both geographically to provide access, but also even within a more concentrated area, we're not going to get much attention from providers or payers or even patients if we don't have a case where providers are being stretched, where patients feel underserved, and where payers realize that they can benefit financially from increasing access to care through technology. And of course, technology itself has to bring clear and compelling value to the evidence-based practice. We don't simply want to give the same level of service, but rather we want to ask the question, how can technology be the next logical step extending and going beyond, not just providing access, but improving the evidence-based practice? And finally, lest we forget, we've got to have evidence revenue-based models that will allow us to achieve not just sustainability, but profitability, at least in terms of the gross profit margin for the care units and for the work that we're doing. So with that conceptual definition of what we mean by a care unit, let's look at some of the early opportunities, care units where the need, the funding, and the evidence-based protocol are in alignment with the technology to yield success today. Certainly substance use disorder. In our work, which is funded by the Substance Abuse and Mental Health Services Administration, we've shown significant improvements in terms of the delay of relapse. Even for a population, and this wasn't an intended consequence initially, a decrease in the rate of recidivism for a group that had come to the substance use programs upon release from jail, which has led SAMHSA to again fund another new care unit focused specifically on criminal justice reentry, applying theories of recovery, focusing on risks, needs, responsivity, to apply the process to, again, lower rates of recidivism, improve success, and improve health outcomes. An e-health coach, which is really a care coordination and self-management approach to physical health conditions. So it's not so much a deep dive into the detail of diabetes or Hep C or COPD, as it is the role that coaches can play and individuals can play in the utilization and behaviors around the management of their health. Are they managing their condition? Brain injury, a huge area that has tremendous opportunity, not just for care coordination and some of the traditional workflows, but taking some of the new online tools that focus on retraining around neuroplasticity to actually provide a new tool that might otherwise be available in a clinical setting and use it from a mobile phone to help people train and refine and advance and heal. Palliative health, the fastest area growing in terms of healthcare today. That notion of improving the spiritual as well as the physical well-being of someone who is dealing with a chronic condition, whatever it is. And of course, pain management, which is increasingly thought of as a chronic condition in its own right. Each of these constitutes an area where we believe we have the low-hanging fruit for telehealth and for improved health outcomes and for improved financial performance. Now, these aren't the only ones, and some of these will, depending upon the state, be more effective than others. For example, brain injury is particularly effective in the 9 states that have Medicaid CMS waivers that allow providers to essentially create their own billing codes, sort of a CPT code that is specific to brain injury, whereas in the other states, they may not have the same levels of funding available through either of their insurers. So we can't assume that each of these applies equally in every case. But these 6 serve as a good starting point, and it will no doubt grow as the industry matures and as we demonstrate success. Now, when we think of that healthcare continuum that Chilmark talks about when they get to the second wave, and when we apply it to each of those care units, we're thinking of each of these steps in the process. Not all of these are purely a telehealth solution. Many of these may be things that are already done in the clinical setting, documented and evidenced in the electronic health record. They may be more or less aligned with the evidence-based protocol, but each of these steps must be considered in order to develop the full healthcare continuum. I want to spend a moment or two on each of these because they're so important. When it comes to engagement, we're not just talking about how do I get people to walk through the door. Certainly, again, using a substance use disorder as an example, people coming from drug courts, engagement is easy. Thou shalt go to the program. On the other hand, for other people who may be looking, the stigma of walking through the front door, of being seen walking through the front door, or the stigma of walking into something like calling a hotline, for example, creates a certain tension of its own. I don't really know what I'm getting into. Not to mention the whole social situation in which a person may live with their boyfriend or their spouse or their family. So certainly lowering the barriers to seeking care is the first aspect of engagement, but that's not all. Increasing the level of participation while in a program, for example, an intensive outpatient program. Increasing levels of adherence by creating community, using social media tools both to lower barriers and to engage more effectively while in treatment becomes a significant driver for improved outcomes. And finally, increasing the duration. We all see this. People go through perhaps an intensive inpatient program. They might then go through an intensive outpatient program. They might then graduate and be sent back to the same community where they were with, shall we say, a lower level of formal supports. If we can use technology and the social aspects of technology to continue and to maintain those levels of engagement without taking a labor cost, then we can vastly improve outcomes while improving sustainability and profitability. Screening. Screening may mean very different things. I'm not sure that screening means for each condition the same level at that first level. Where should this person be? What am I screening for? What is the care broadly? But for example, for people coming out of prison, that notion of screening is critical. What was the nature of the offense? Where is this individual on a high level in terms of risks, needs, responsivity, so that we do not create inappropriate settings of mixing people with different sets of needs that may in fact conflict with each other. Assessments. Assessments is a tricky and critical piece of the entire process. The notion of evidence-based practice often focuses on the role of assessments as well as plan and interventions and adherence and outcomes and measures, but it all starts with the assessment. So, for example, again, using addiction and substance use disorder, when we focus on the recovery-oriented system of care, which, in my understanding, is a rather loose protocol, but there are well-established tools within that protocol. For example, Bill White's excellent recovery capital scale. That may serve as, and it does serve as a fairly common assessment tool that allows me to measure where an individual is today and where he is 6 months later, or where the population is at the start of a program and 6 months into a program. So we have these assessment tools that exist today in many cases. Now, we don't always have them. For example, in the eHealth Coach, we've learned that from that behavioral health side, from the care coordination side, the market for assessments is less mature. There are fewer ubiquitous solutions that apply that everyone will quickly and readily accept. In the case of the eHealth Coach, for example, we worked with the Center for Disease Control to kind of back engineer the Behavioral Risk Factors Surveillance System, BRFSS. You may be familiar with that. It's often thought of as a great population tool to determine health behaviors across a state or the nation. Well, we can kind of back engineer with the CDC's help that to create an individual assessment, a point in time. How are you doing compared to your population? We can also, from that, enhance it by adding readiness rulers for each of the domains we might be looking at. How important is it for you to manage your medications, to stop smoking, to manage your diabetes? How confident are you that you can accomplish your goal? How timely, how urgent is it for you to undertake this management? So adding readiness rulers is a huge step to adding to the value of the BRFSS assessment. And then further adding in components that will let us understand where is this individual following perhaps a stages of change model. Are they in a contemplative, a pre-contemplative? Are they in a sustaining state? All of those things can be incorporated into the assessment following evidence-based practice appropriate to that care unit. They, in turn, inform the plan so that when we sit with the individual, and here the plan does not reside solely in the electronic health record, the plan in particular becomes a dynamic tool that is owned equally, and ideally owned more by the patient than owned by the clinicians, where the patient owns progress of that plan and can influence it and document it, him or herself. That plan is directly informed by the assessment, so that there's a clear linkage as we look at each of the domains in a plan, why we are proposing what we are proposing or requesting. And that in turn says, based on that, we know what interventions to record. We then know what adherence levels to capture, not just using text-based reminders, but perhaps text-based confirmation. Did you do the thing you said you were going to do? How are you doing 2 hours later? Are you getting the results you expected from that intervention, the outcomes, both short-term outcomes and long-term outcomes? And when we aggregate that, we have the ability to look at population health, and then from that, based on the revenue model, to consider operating efficiency and the revenue contribution. Each of these things must be addressed, whether it's in the EHR or whether it's in the telehealth solution, to make sure that we have the right information, particularly information coming directly from the patient or informal caregivers. So that's what we do. We try to provide a platform for community care coordination and patient activation, but also for patient support across primary behavioral, physical, and social supports. So there are online and mobile solutions. There are social media components. There are evidence-based practices behind the walls in the clinical setting. There are care units to support cross-functional care. People don't have one care unit. They have more than one care unit most often. So being able to configure a dashboard that reflects the particular combination of care units for an individual is key. Then being able to get at analytics and reporting, not just of what the patient is doing, but what we are doing as clinicians, becomes key. All of which also needs to be supporting meaningful use stage 2 and all of the quality measures that we know and are growing to love. This is an example of the Recovery Engagement Center. This is Centerstone of Indiana. This particular shot is of their substance use recovery engagement center. I won't spend too much time on it today. I'll look forward to giving you more detail, and hopefully when we have a chance to really demonstrate all the things that we're doing that go beyond what you see here. But it has certain components. The community, the people drive the blogs that you see on the lower left. It's a milestone to be able to submit your own thoughts and contribute to that dialogue. There's a topic of the day to allow people to communicate and talk about what's on their mind. That discussion board proves to be amazingly important. People will talk about the upcoming event at such and such a parish on Memorial Day weekend. It's amazing how many people then spread word, so it becomes local as well as global in its outreach. We also have on the lower right, you'll see the leave a message. Well, that may also be someone logging in to have a live chat with someone. And the time that is manned mostly is the middle of the night by peers, people who are in the program and are qualified then to serve as a peer support person in the middle of the night for someone who needs someone to talk to chat with. A level perhaps below an emergency hotline where I can speak to someone who is local. And then, of course, the ability to request an appointment, which is so important to lowering the barriers and allowing people to come in on their own. We could drill into this more, but for the moment, we'll leave it with that. Now, when we log in from the coach's view, and this is just one example, again, this is substance use disorder. This shows data captured generally by the individual, from the individual, him or herself. In this case, we're looking at another evidence-based tool, the results of something called the Telephone Monitoring and Adaptive Counseling Tool by McKay and Company. And that tool measures over time, as people progress, the blue line, protective factors and behaviors, the red line, risk factors and behaviors, and the green line, sort of a net position over time. So we can see here kind of a not uncommon pattern. Initially, someone comes in and risky behaviors are greater than protective behaviors. Initially, that kind of swings very quickly, and boy, oh boy, I'm doing a lot of protective things, and I'm going to master those risk things. That gets a little hard to maintain for a period. And what we find is that about 5 periods in, milestones, not necessarily time, because some people do it quicker than others, but milestones into an IOP program, we find that perhaps there's really a rough spot. And then if they make it through that rough spot, as they make it through that rough spot, then we find a restoration and a progress. You'll see what that looks like from a population level in just a moment. We also have from the individual side a dashboard that allows you to be able to manage my particular set of chronic care units. So recovery may be one. The eHealth coach may be one. Employment may be one. I may have my today's task list, and then within each of these I can drill and say, what is my goal? What are my tasks to achieve the goal? How am I doing? And really have its own management appropriate to that care unit. Again, we'll drill into this more when we have a chance to speak together. And of course, it has to be today a mobile solution so that I can come in and look at what are my goals. I can interact with it. I can do the things to keep myself in touch from a social or from a workflow perspective. Now, this is an example just to show you, begin to get into a little bit of analytics. This shows an example of how people have progressed as a population. This particular group was funded by a SAMHSA grant. And so these are people that were in this for generally 6 months or so, and we can see a certain progression over time that is of a positive in nature, as evidenced by that green line. Here's an interesting example. Again, this is Centerstone of Indiana. In the first 6 months, we found, as you saw in the example we looked at a moment ago, that at period 5, there is a rough spot where the protective factors are diminished, where the risky behaviors are increased. And if you can get people through that, then they continue as though there was no disruption. But there's also a high dropout rate at this point. So when we saw this data, we went back to our client and said, we don't know what this is, but we can see it every which way we slice it and dice it. And our client said to us, well, this is clearly, we know what that is. That's when the person has gone back home and the point has realized that this is a permanent change, a life change, and it's not as easy as they might have hoped. So we asked the client, what can we do? How can we modify the clinical behavior? What can we do with the technology to perhaps help your clinicians to guide people through this difficult spot? 6 months later, we could see that the pattern was clear, that disruption is managed. Now, there still is some risk, some increased rate of people dropping out, we notice, at about period 5. But on the other hand, we are seeing a significant improvement compared with before we were able to capture this data and then track and make a change and then track the impact of that change. So how do clients use this broadly? Let's just spend a second. I've talked about telehealth. I've talked about the continuum of care. What does it really mean in terms of outcomes that we're trying to achieve? Well, we're trying to certainly increase revenue and the net margin under Medicare models today, and I believe quickly following insurance payment models, Medicare and Medicaid and following with insurance. We're certainly trying to improve operational efficiency, which means replacing services that are done and require someone's time, face-to-face or on the telephone, with things that we can do more efficiently, with more gratification for everyone through the use of technology. The ultimate measure might be increasing the number of patients or participants we can see for the same level of staff, for the same or higher levels of outcome. If we can improve the capacity by 15 or 20%, that's a huge operational efficiency. And of course, it's all nothing if we don't have improved outcomes, which means lowering rates of relapse, lowering rates of recidivism, improving measurable recovery capital, decreasing the use of inpatient emergency services, and certainly the rate of readmission, and of course, improving patient satisfaction, all while meeting the requirements of meaningful use stage 2. Now, this isn't really competition per se, but it's a good way to look at it. People will say, what are we doing that's different than what I might have from a traditional EHR patient portal or from the early telehealth solutions that are video telehealth only, or independent patient portals that are now beginning to crop up? And I can think of some great diabetes portals from the American Diabetes Association, or Heart 360 from the American Heart Association. And of course, personal health records, which have never fulfilled the promise that we would like to think they could fulfill. This gives you a sense, but I think the key points are the notion of a complete telehealth solution, the notion of configurable care units for specific conditions, and then the ability to manage cost and, frankly, with it, operational efficiency. Those are the key things we're trying to drive. Finally, I thought rather than my talk to you, let me invite you to click on this link. This is something that Centerstone prepared for a recognition event in September of 2013. Centerstone was recognized by SAMHSA and the National Institute of Health at an event at the White House. And for that, they prepared this 5-minute tube, which includes commentary by clinicians as well as commentary by people who are using these systems to use what we call the electronic recovery-oriented system of care. Well, that concludes the introduction. In a way, I feel like I've only touched upon the tip of the iceberg, and I hope I've got your interest. I look forward to speaking with you so that together we can learn from each other and take advantage of this rare and wonderful opportunity. Thank you. Goodbye.